Good afternoon, everybody. I'm Dr. Pratik Kande, Governing Council member of ICOG and Chairperson for a Mobile Technology Committee. Welcome to today's event, which is the next in the TOG Experience series. We've had a series of events in this series which are highlighting the fetus specifically and the issues related to perinatal morbidity and mortality. And today we have two illustrious speakers in the shape of Dr. Alpesh Gandhi, sir, our past president of FOXI, and Dr. Anjana Khanna, our past vice president of FOXI. We'll be speaking about two very distinct and unique topics. But before we hand over to the chairpersons, I think I should formally introduce the chairpersons first. Next slide, please. I'm delighted to welcome our very own Dr. Sarita Bhalerao, madam. She's recently been elected the secretary-elect of ICOG. She's been a governing council member of ICOG, of course, for the past 5 years. She served as the president of the Mumbai Society in 2021, joint secretary of FOXI in 2017, when Dr. Rishma Devanpai was the president. She's also the past president of ANWI Mumbai branch and the chair for the AICC RCOG West Zone. Madam is driving. She will be logging in very soon, and we hope to see her very soon. Next slide, please. I'd also like to introduce Dr. Hafizur Rahman. Sir is a professor of OBGYN and a co-governing council member of ICAG along with me. He has over 65 scientific research publications in national and international index journals, peer reviewer on the board of several journals. He's won the Foxy Future Award in 2017, several other Foxy awards to his credit. We are very happy to have Sir with us because it's a working day and in the afternoons, I'm sure he must be at work at the medical college. So thank you for sparing your precious time and being with us. Without further ado, I'd like to hand over to Dr. Hafizur and I would request him to please introduce our first speaker, Dr. Alpesh Gandhi, sir. Yeah, Dr.
Thank you.
Please go ahead.
Madam. So today we are having with this is very important times of gynecology series where we hardly give focus on that is fetus focus. So today important topic is the fetus. So we have this research Imin and Alpesh Gandhi sir, that is he need introduction, but still for take there is need to tell sir had been president in 2020 when the COVID came. And when almost the entire world stopped, but still the academics were the effort and all the steps by Gandhi sir. So he has been the resource person for GCP around and COVID-19. And with the COVID-19, even for the neonatal registry and resource person in so many speaker in obstetrics and sir has also contributed his young principles of critical care in obstetrics and gynecology. He has awarded him with honorary FRCOG and the Best Society, Best RCS Activity, and Best Publication Award from FOXI. So he has been the convener of the most successful AICG 2017. So sir has been practicing in
I think Hafizur has some internet issues. I think we should go ahead with the first speaker, requesting Dr. Alpesh Gandhi sir to please share his screen. Get started.
yeah. So we would like to hear Alpesh Gandhi sir.
Thank you very much for the kind introduction and inviting me for this very important meeting and important topic. I am thankful to all the organizers for giving me this opportunity. I can see Dr. Pratik is sitting like in a corporate office, a very good backdrop with him, and he is drinking coffee, and he has not sent coffee for me. So without coffee, I am going to present my topic, and I'm two dear chairpersons, Dr. Sarita and Hafizur. My regards to you, I'm coming to my topic. I'm going to speak on a topic that is neuroprotection, the obstetrician's perspective that is very, very important. And 1 minute. Yeah. So in next 20 minutes, we'll see why it is important, what is our perspective, and what we can do for the fetal neuroprotection. So to begin with, when this is a very famous movie and very famous ship, Titanic, when it has started its maiden journey for the first time, there was an atmosphere of celebration. Everybody were excited. There was so much happiness. They were greeting each other and they were ready for the journey. So similarly, when pregnancy is, when we identify pregnancy, when the family members come to know that she is pregnant, there is all are excited in the family. There is happiness. They are celebrating the news and they are waiting for the new comer to their family. But and like this, they all are enjoying in the family. But when suddenly, if any complication occurs during pregnancy, then they all are worried. The anxiety turned into the happiness turned into anxiety, and they all are worried very much what will be happen to the mother and what will happen to the fetus baby. Similarly, and at the same time, when any complication occurs, immediately we need to take some life-saving measures like the jackets and lifeboats and like that. So we have to be very much aware. We have to be very much alert, and immediately we need to take some actions to prevent the disaster in the family. Otherwise, it can lead to the disaster. We may lose mother or baby or both. So many complications can occur. So we should always keep our setup ready. We should always suspicious it. We should always try to predict it. We should always try to identify high risk mother who is going to have this problem, and we should always keep our setup ready. We should always we should continue counseling with the patient and her relatives, and we should also train our staff to tackle any such disaster. And preterm labor is very much one such type of disaster where we can where the fetus, the baby, newborn, newcomer going to the family can be at a very high risk. And so we always should have suspicious, and we should always try to save such type of disaster. So at the beginning, very briefly, I would only like to mention about what is preterm labor. Then preterm labor is defined as regular uterine contraction that occur between 20 to 37 weeks of gestation and are associated with cervical changes. When it occurs before 28 weeks, then it is considered as the extremely preterm. When it occurs between 28 weeks to 33 weeks and 6 days, then it is early preterm. And when it occurs between 34 to 37 weeks, it is considered as the late preterm. And the complication related to this extreme preterm, early preterm, and late preterm are also differ, and particularly severity is differing. Why it is important to manage preterm delivery? Because 120 million babies are born every year in the world by preterm delivery. Out of these, 2 million baby die in the first 4 weeks of their lives, and that is, we can say, neonatal period. The three main direct causes of neonatal death globally are preterm birth, severe infection, and asphyxia. Half of the babies, preterm baby, who survive after the preterm birth may develop long-term neurological disability, may face CP, may have learning disability, visual or hearing problem, and many other neurological problems they can develop. Unfortunately, as per the 2022 WHO statement, India is one of the country. India is the country having the highest number of preterm delivery across the world. As per the WHO 2022, 3.5 million babies are born preterm in India. So it's a substantially high number, though there is a a very good improvement in India, but still high number of preterm babies are delivered every year. And India, again, sad part is not only the preterm birth, but the death because of the prematurity is also highest in India in the world. 35 lakh infant in India are born premature. Out of these, 3 lakh babies die due to complications of prematurity, and those who delivered between 500 to 999 gram may require NICU stay for 30 to 40 days. Those who delivered with birth weight of 1215 gram may require NICU stay for 15 to 20 days, and this leads to a great financial burden to the family, to the healthcare sector of the country, and further they may develop neurodevelopment. There may be a neurodevelopment impairment in survivor, which may add further economical burden to the country. So when preterm delivery is there, it can lead to neonatal death, intraventricular hemorrhage, cerebral palsy, ARDS, necrotizing enterocolitis, jaundice, infection. It can lead to retinopathy of prematurity. It can lead to hypothermia, hypoglycemia, and many behavioral problems can occur to the neonates. So many complications can occur, and preterm, they are having a higher chance of dying in the first few weeks of life, and when they survive, as I mentioned, neurological impairments means it can lead to cerebral palsy, cognitive dysfunction, educational difficulties, psychiatric disorders can occur in the adulthood with increased, of course, educational and societal cost. These are the high risk. I am not going in detail. We have to identify this high risk factor, and we should offer screening to prevent preterm delivery, to predict preterm delivery and prevent it. We should offer the screening to all by identifying the modifiable risk factor, non-modifiable risk factor, and offering cervical length measurement to all while performing sonography between 18 to 22 week scan. And those who are at a higher risk having a uterine anomaly or previous preterm delivery, history of preterm previous delivery, should offer cervical length measurement from 14 weeks onwards, and we should do per speculum examination for the screening for vaginal infection and bacterial vaginosis. But the important thing is, once we come to know that this mother is high risk for the preterm delivery, we should do counseling. And when she is eminent to preterm delivery, when we think that this mother is going to be delivered within 24 hours, in spite of all the measures taken, I think Dr. Ranjana is going to speak on all these measures, what should be done to prevent preterm delivery. So, but when we come to know that she is going to deliver now within immediate period, within, we can say, in 24 hours, then another important role of obstetrician is our worrying always about this neurodevelopmental problem, and we can play a significant role in preventing some of these problems and can help the newborn. So what we can do is, the MAC-SULF is has a very magic role. We can see it has a very significant effect on neurodevelopment problems. Of course, it has it can be helpful in hypertensive disorder in pregnancy. Of course, it is not the drug of choice, but it has some effect on hypertension disorder in pregnancy. It is the drug of choice for the imminent eclampsia. It can have a role in preterm labor. It can also be helpful in preventing preterm labor for few hours or few days. So, but here we are interested in discussing its role in fetal neuroprotection. So it has other significant role in HDP, imminent eclampsia, preterm labor, but one important role is fetal neuroprotection. So when preterm labor refers to progressive, as we have discussed, when there is a cervical dilatation, progressive cervical dilatation or effacement associated with regular uterine contractions, and when we are thinking this patient is going to be delivered within few hours or within a day or two, then we may need prophylactics are used to delay the active phase of labor for at least 48 hours, maybe because of some, of course, steroid might have been given before or not given. We may want some time to give steroid. So there, or we may need to ship the patient to the tertiary care center where NICU facility is there. So for so many reasons, we need to prevent or we want to delay the active phase of labor for few hours by using tocolytics and magnesium sulfate, prostaglandin inhibitors, calcium channel blockers, and nitric oxide releasing drugs have shown benefit in this woman. The use of tocolytics such as magnesium sulfate in preterm labor is well established, and we'll see next few slides how it is helpful and which what are the studies. So first report of Maxell as a tocolytic was published in 1977. Which was followed by the largest case series in the literature in 1983, where 355 patients were treated with Maxell as a tocolytics. Patient had multiple other morbidities such as amnionitis, placenta abruption, premature rupture of membrane. In this study, the finding were in singleton gestation with intact membrane, 76% of these patients' mothers gained 48 hours before delivery, 51% gained 7 days, 1 week, and 39 achieved a full-term delivery with the role of magnesium sulfate as a tocolytic. So it has significant role in preventing preterm delivery, in preventing active phase of preterm labor for 48 hours or up to 7 days. Another study was published where Maxell was compared with the placebo. In this study, the aim to investigate the effects of magnesium sulfate on delay in reaching the active phase of labor in women with premature rupture of membrane and subsequent fetal complication. 92 women were divided into two groups. In one intervention group, Maxell was given. In another group, it was considered a placebo group, and Maxell was not given. Maxell was given in the dose of 4 grams of magnesium sulfate was dissolved in 100 ml of normal saline solution and administered intravenously over 20 minutes. After that, 2 grams of Maxell dissolved in 100 milliliter of normal saline per hour given by infusion. The infusion was continued for 24 hours after complete cessation of uterine contractions. Both groups received corticosteroids, and antibiotics were also given, azithromycin, ampicillin, and amoxicillin were given in different cases or an additional 5 days. And the findings were Maxell was a delay in delivery for at least 48 hours. Magnesium sulfate increases this period 2.7 times the same as in control group, which we can see in this graph. As at the gestational age, when it was less than 30 weeks, magnesium sulfate led to delay in 77% of the cases, 77% of women, 87.7%. At least 87.7% at 30 to 31 weeks and 72.7% at 32 to 33 weeks of gestational age. The result was the chance of respiratory distress syndrome in infants who had received magnesium sulfate was 80% less than those who had received placebo, and there was no case of chorioamnionitis or adverse effect reported. The conclusion of this study was magnesium sulfate delays the active phase of labor in mothers with PROM and prevents adverse birth outcomes. Again, this 192 women in active preterm labor were given Maxell versus nifedipine study was conducted. And these mothers were between 24 to 33 weeks of gestation. All patients received betamethasone and antibiotic, and they were divided into two groups. One intervention group which has received Maxalp, and another group nifedipine was given as tocolytics. Maxalp was given 4 gram bolus. Maxalp was given, followed by a maintenance dose of 1 gram per hour. Physicians were allowed to give additional 2 gram magnesium sulfate boluses as if needed, and to increase the infusion rate up to 4 gram per hour if required. In nifedipine group, 10 milligrams sublingually was given every 20 minutes for 3 doses total, and then followed by 20 milligram orally for 4 to 6 hours based on clinician's judgment. The primary outcome was arrest of preterm labor, defined as prevention of delivery for 48 hours with uterine activity were stopped. When it was compared, then the arrest of preterm labor was 87% in case of Maxalp, and in case of the group in which Maxalp was given to mothers, and in nifedipine group, arrest of preterm labor was observed in 72% of the mothers. All other parameters like gestational age at delivery, delivery in 48 hours, neonatal outcomes were similar between these two groups. So conclusion was patients who received magnesium sulfate achieved the primary outcome more frequently. Again, the inhibits uterine contractions and delays delivery by delaying the active phase of labor. Maxalp can arrest preterm labor, significantly reduces the incidence of respiratory distress syndrome, and babies born preterm compared with those born at term have a higher chance of dying in the first few weeks of life, as already discussed. But those who survive can have neurological impairment, already we had discussed. And antenatal magnesium sulfate is recommended for neuroprotection of the fetus in women at risk of preterm birth, because we want to prevent this neurological impairment. And magnesium sulfate, antenatal magnesium sulfate, is found to be very useful and has effective role in preventing neurological impairment as the neuroprotection of the fetus. When preterm delivery occurs, it can lead to two types of CNS injuries. Pathologically, it can be intraventricular hemorrhage, usually diagnosed by ultrasound, or it can have white matter injury, which can be diagnosed by MRI. Clinically, the most frequent adverse CNS outcomes in preterm delivery are cerebral palsy, cognitive impairment, blindness, deafness, and developmental delay. We want to prevent all such type of complications. So coming to cerebral palsy is a disease that affects movement, muscle tone, motor skills. The incidence is 1.5 to more than 4 per 1,000 live births or children of a defined age range. And again, sad part is the incidence of cerebral palsy increases because due to increased survival of preterm infant. Now, mortality, neonatal mortality, because preterm delivery is decreasing, but at the same time they are survived, and when there is surviving, and half of these babies may develop, those who survive the preterm labor may develop neurological problems and may develop cerebral palsy. So the incidence of cerebral palsy increases also. Injury to developing brain can occur at any time during prenatal period, perinatal period, or even during postnatal period. During prenatal period, maybe because of the rubella or cytomegalovirus infection, or maybe because of the blood or oxygen delivery to the fetus is reduced, or during perinatal period, maybe because of the birth defects, maybe because of the preterm birth, maybe because of the intrauterine growth restriction, maybe because of the multiple pregnancies and natal events, and sometimes maybe because of the operative instrumental delivery. Even during postnatal period, maybe because of sometimes because of head trauma or cerebral infections. Because of all these things, brain injury, injury to developing brain can occur at any time. And Maxalp has multiple mechanisms may underlie the neuroprotective impact of magnesium. Magnesium is a non-competitive antagonist to the glutamate NMDA receptor, can block calcium influx into the cell, can block neuronal injury. It can stabilize the stabilization of the membranes. It can increase cerebral blood flow. It can prevent large blood pressure fluctuations. It can reduce in pro-inflammatory cytokines, and it has antioxidant effects. So it has various effects, several effects which are benefited for the neuroprotection. So MaxHelp has various mechanism of actions, how it can be helpful for the neuroprotection. There are several guidelines, there are several studies which suggest the significant role of MaxHelp as the neuroprotector. Coming to our own parental body, FIGO has good practice recommendation on magnesium sulfate administration for preterm fetal neuroprotection. FIGO came out with very clear guidelines in women at risk of early preterm imminent birth from viability to 30 weeks of gestation. Use of MaxHelp for neuroprotection of the fetus is recommended. So when from viability to 30 weeks, all the fetus, all the newborn baby who are going to be delivered by all the fetus who are going to be delivered by preterm imminent birth should receive MaxHelp. MaxHelp is recommended to all such fetuses in pregnancies below 32 to 34 weeks of gestation. The use of MaxHelp for neuroprotection of the fetus should be considered. So here, FIGO has advice for the consideration, and it depends on the clinician's judgment. MaxHelp should be administered regardless of the cause of preterm birth and number of babies in utero. When birth is planned, MaxHelp should commence as close as possible to 4 hours before birth. So, even if it is delivery is imminent within 4 hours, then also FIGO has suggested the role of MaxHelp. If delivery is planned or expected to occur sooner than 4 hours, MaxHelp should be administered, as there is still likely to be an advantage for administration within this time. So it is not that only when we have 24 hours we should administer MaxHelp, but when only 4 hours are left and she is having imminent preterm birth, it should be given. The optimal regimen of MaxHelp for fetal neuroprotection is an intravenous loading dose of 4 grams administered slowly over 20 to 30 minutes, followed by 1 gram per hour maintenance dose. This regimen should continue until birth, but should be stopped after 24 hours if she is not delivered. Another guideline, another recommendation, ACOG recommendation for MaxHelp as a neuroprotection. It should be available. There are available evidences suggest that magnesium sulfate given before anticipated early preterm birth reduces the risk of cerebral palsy in surviving infants. So they have mentioned that it has significant role in preventing cerebral palsy. Magnesium sulfate reduces the risk of cerebral palsy, and that is why it should be given to all those fetuses who are having anticipated early preterm birth. Again, a guideline recommendation of MaxHelp for neuroprotection: women with preterm labor, preterm PROM, or fetal indication for delivery at 23 to 31 weeks, 6 days gestation should receive magnesium sulfate for fetal neuroprotection. Exclusions: when there is evidence of renal insufficiency or other medical conditions like myasthenia gravis, for which magnesium sulfate would be contraindicated. So except these few conditions where magnesium sulfate is contraindicated, otherwise it should be given to all the fetuses likely to be delivered between 23 to 31 weeks and 6 days gestation for fetal neuroprotection. Magnesium sulfate is recommended for fetal neuroprotection. Again, coming to a very important organization, WHO recommendation is very clear. Strength of recommendation here is strong. Magnesium sulfate is recommended for women at risk of imminent preterm birth before 32 weeks of gestation for prevention of cerebral palsy in infant and child. This recommendation applies to women carrying either singleton or multiple pregnancies. So WHO also suggested its significant role before 30 in case of imminent preterm birth before 32 weeks of gestation. So it should be given to all fetuses likely to be delivered before 32 weeks of gestation. And there are other several guidelines. We will not go in all these guidelines, but if we look at here, then all the guidelines have suggested significant role of Maxalp as the neuroprotector, and the loading dose mentioned by all the guidelines are same. Loading dose 4 gram of Maxalp slowly IV in normal saline over 20 to 30 minutes it is given. WHO has not specified the loading dose, and maintenance dose is 1 gram per hour until birth, maximum up to 24 hours is the maintenance dose by all the guidelines, may it be Australian, New Zealand, Canada, Ireland, Belgium, United Kingdom, FIGO, WHO, France, USA. Any guideline we take, all the guidelines are suggestive of the same loading and maintenance dose, but only difference is regarding the retreatment. Retreatment is possible as per the Australian, New Zealand, and Ireland guidelines, whereas other guidelines there is not they have not specified about the retreatment with the Maxalp is should be done or not, and the period of the maximum gestational age is different in different guidelines, but we can say from the age of viability to all the guideline, majority of the guideline are suggestive of 31 plus 6 days, means we can roughly say 32 weeks. So up to 32 weeks, all the guidelines are suggestive of use of Maxalp for the neuroprotection. United Kingdom guidelines suggestive up to 33.6. We can say this guideline suggests up to 34 weeks. We can use Maxalp for neuroprotection. So there are some clinical trials coming to the important trial conducted in India for efficacy of antenatal magnesium sulfate for neuroprotection in extreme prematurity. A comparative observational study was conducted in which 100 pregnant women who had preterm birth were divided into two groups. So in one group, intervention group of Maxalp magnesium sulfate was given 4 gram IV loading dose in 100 ml, normal saline over 30 minutes, and preferably 4 hours prior to preterm birth, and then maintenance dose was not administered in this group, in this study, and control group there was no magnesium sulfate was given. So result was the infants who received Maxalp were less likely to require invasive mechanical ventilation compared to control group. Magnesium sulfate had a protective effect on the need of invasive ventilation in preterm infants. In neonates with antenatal exposure to Maxalp had more days free of respiratory support in the first 28 days of their lives, hence protecting the neonates from the adverse effects of excessive oxygenation. And we all know that excessive oxygenation can lead to retinopathy of prematurity and other complications. Another prospective RCT where 50 pregnant women who had preterm birth, a study was conducted. Again, they were divided into two groups, interventional group and control group. And dose was same, 4 gram IV loading dose in 100 ml of normal saline over 30 minutes, preferably 4 hours prior to preterm birth, and maintenance dose was not given. And here, the study was conducted at Raja Muthiah Medical College and Hospital Chidambaram from October 2019 to October 2021. And the inclusion criteria was all pregnant women of gestational age between 28 to 34 weeks in labor who would to deliver in next 24 hours. And the result was 60% of the newborns had normal neuronal development, whereas 30% had mild and 2% had moderate neuronal abnormalities. And the infusion delivery interval, 80% of deliveries occurred after 13 hours. So again, this suggests that a significant role in prevention of it as a prevention of neuroprotection as a significant role. And again, the Apgar score was 1 minute at 1 minute was 5.78 plus or minus 1.64, and 77.44 at 5 minutes. About 92% of the neonates were normal. So conclusion was magnesium sulfate given for neuroprotection before preterm birth avoids cerebral palsy and lowers the combined risk of fetal infant death or cerebral palsy. Significant neuroprotective advantage to the neonates, and it is safe drug to use in antenatal women. In this all the studies, there are no significant adverse effect were observed. Again, in there was a trend towards reduced risk in magnesium sulfate group for intraventricular hemorrhage, neonatal hypotension, hypothermia, and length of NICU stay. Intraventricular hemorrhage was less frequent and less severe in babies exposed to antenatal magnesium sulfate over control group. In comparison, when Maxel was given, only 8% where fetus were having intraventricular hemorrhage compared to 16% in the control group. So there is a significant improvement in intraventricular hemorrhage incidence also. So in conclusion, magnesium sulfate is a safe drug to use in antenatal women at risk for impending preterm. Antenatal magnesium sulfate conferred significant neuroprotective advantage to the neonate. It is the time to start using Maxel in clinical practice for neuroprotective intent in all our extreme preterm births. Another prospective RCT with 1,000 plus women, 1,062 women with fetuses younger than 30 weeks gestation for whom birth was planned or expected within 24 hours were enrolled. Again, two groups, intervention group, control group. In intervention group, 4 gram magnesium sulfate was given as a loading dose. Then maintenance dose was given of 2 ml per hour for up to 24 hours. In control group, isotonic sodium chloride solution only was given. Rates of total pediatric mortality, cerebral palsy, and combined outcome of death or survival cerebral palsy at a corrected age of 2 years were studied. And what they found is in saline solution, pediatric mortality was 17.1%, whereas in Maxelf it was 13.8%. In cerebral palsy, in survivor, in saline group it was 8.2%, whereas in Maxelf it was 6.8%. Combined death or cerebral palsy was found in 24% in saline group, whereas in Maxel group it was 19.8%. Gross motor dysfunction was found in 6.6% in saline group, whereas it was found only in 3.4% in Maxel group. Combined death or substantial gross motor dysfunction 22.7% in saline group, whereas 17% in Maxel group. So the conclusion was magnesium sulfate given to women immediately before preterm birth may improve important pediatric outcomes. No serious harmful effects were seen. And Maxel, in this again very important trial, effect of magnesium sulfate on mortality and neurologic morbidity of the very preterm newborn with 2-year neurological outcome, a randomized control trial was performed. 573 women less than 33 weeks, whose birth was planned or expected within 24 hours. Again, two groups, intervention group, control group. In intervention group, they received a single injection of 0.1 milligram Maxel per liter, 4 gram over 30 minutes. Isotonic sodium chloride in control group was given. Result was decrease of all primary endpoints, total mortality decrease, severe white matter injury decrease, their combined outcome improved, and all secondary endpoints, motor dysfunction improvement was there, cerebral palsy incidence decrease, cognitive dysfunction decrease, their combined outcomes at 2 years of age in Maxel group was decreased. Result was the decrease was significant for gross motor dysfunction and combined criteria. combined criteria: death plus cerebral palsy and death plus gross motor dysfunction and cerebral palsy plus cognitive dysfunction. Conclusion given was its beneficial effects and safety. The use of prenatal low-dose magnesium sulfate for preventing neurodisabilities of very preterm infants should be discussed either as a stand-alone treatment or as a part of combination of the treatment, at least in the context of all these clinical trials. And meta-analysis of 5 RCTs with 5,235 patients effects of antenatal exposure of magnesium sulfate on neuroprotection and mortality in preterm infants. A meta-analysis conclusion was fetal exposure to magnesium sulfate in women at risk of preterm delivery significantly reduces the risk of cerebral palsy without increasing the risk of neonatal death. Cochrane review 2009, magnesium sulfate significantly reduces the risk of cerebral palsy in child, substantially gross motor dysfunction at 2 years of age. Magnesium sulfate had no significant effect on pediatric mortality as per the Cochrane review, means fetal neonatal later, and the number of women needed to be treated to benefit one baby by avoiding cerebral palsy is 63 as per the Cochrane review. And SOAG clinical guidelines for women with imminent preterm birth less than 31 plus 6 weeks or equal to 31 plus 6 weeks, antenatal magnesium sulfate administration should be considered for fetal neuroprotection. So what is imminent preterm birth? Imminent preterm birth is defined as a high likelihood of birth due to one or both of the following conditions: active labor with equal to or more than 4 centimeter of cervical dilatation with or without PPROM, and planned preterm birth or fetal or maternal for fetal or maternal conditions indications. So these two are the criteria from which we can identify the imminent preterm birth. We can define the imminent preterm birth, and as per this guideline, when it is less than 31 plus 6 weeks or equal to 31 plus 6 weeks, it should be given to all the mothers having imminent preterm birth. So in summary, magnesium sulfate is a wonder drug. It has many effects. Not only we all are knowing about its effects on hypertensive disorder in pregnancy and in eclampsia to prevent the convulsions, and we are also knowing its effects on as tocolytics, but it has a very significant effect even as a neuroprotection for the preterm baby. Magnesium sulfate is recommended for the neuroprotection of the fetus in women at risk of very preterm birth, and we can define how a patient who is having very preterm birth, imminent preterm birth, from the definition. And there are several studies, several guidelines, all are speaking in a same direction, same language, on the same, they all are on the same page, that magnesium sulfate is recommended for the neuroprotection of the fetus in women at risk of very preterm birth. Significantly, it reduces adverse clinical outcomes in preterm birth. Significantly, it reduces pediatric mortality and cerebral palsy incidence. And we know how much it is, impact of cerebral palsy on the patient as well as on the family. And this has magnesium sulfate has a significant role in reducing the incidence of cerebral palsy also. Despite clear benefit of magnesium sulfate and despite the well-established superiority of magnesium sulfate in the management of severe preeclampsia, eclampsia, and preterm birth, it continues to be used suboptimally in India. At least it is also used suboptimally for these reasons, but it is also used suboptimally for the protection of for the neuroprotection in imminent preterm birth. It should be ready to administer solution will dissolve. A ready to administer solution will resolve the errors in dosage calculation and associated complications. It would be a welcome step if we have a saline, 100 ml of saline ready with 4 gram of magnesium sulfate, then our so many efforts will be reduced, as well as particularly solution to prepare the solution as per the proper dose will also be we can have ready solution. So thank you very much for your patient hearing. I thank you very much once again for giving me this opportunity.
Thank you,
Thank
Dr.
you so
Alpesh
much,
Gandhi,
sir.
sir. Yes, sir, please go ahead.
Yes, sir. Thank you so much, sir. I think it has been very much elaborative, and because of the time, sir could give us so much information, and that is really nice going through all the evidences, as we know. And I'm sure this is going to give us some solid as well as some important information to bring out in clinical practice. Thank you so much, sir. Yes, sir, Pratik.
So thank you very much, Dr. Alpesh Gandhi, sir, for being here with us. It's always wonderful to reconnect with you, to listen to you. I remember listening to you 15 years back when I was a youngster. You were the person who guided me actually as to how to go ahead in Foxy, how to start working for committees. So hats off to you for your commitment, even
And I am
now,
happy to
15
see
years
your
later.
progress, and I am
Thank you,
also
sir.
happy to see your progress in Foxy.
Thank
You
you,
had
sir.
already reached to local joint secretary, and I want to see you even on the higher positions.
Thank you, sir. Thank you. That is so kind of you. We have